Now we'll discuss about the clinical findings in pneumonia. We already have understood about the symptoms, the presentations of pneumonia, which are typical and atypical presentations coming to our hospitals. Now let us move forward into the clinical findings in pneumonia. So what we see typically in a patient who presents or who is diagnosed as pneumonia, at first we can clearly see that there is increased respiratory rate in that particular individual. Then on inspection there is nasal flaring, there is intercostal retraction, asymmetrical chest movement on the affected side. Mind you that these presentations, the clinical findings in pneumonia, is no more of high value in our hospital settings, as most of the patients will come to you after taking 2 to 3 days of antibiotics. So the classical presentation of pneumonia is rarely found these days in our hospital setting. So to continue our discussion on the clinical findings in pneumonia, we already told that on inspection there will be nasal flaring, intercostal retraction, asymmetrical chest movement. On palpation, there will be reduced chest expansion on the affected side with increase in vocal fremitus. On percussion, there will be woody dullness over the consolidated area, and on auscultation, we'll find bronchial breath sound on the affected side, crepitations or crackles heard, and increased vocal resonance. These are the typical findings we get in a patient of pneumonia. Also, cyanosis can be seen in severe cases. Now, moving forward into the differential diagnosis of pneumonia. It is a common question asked in our vivas in our wards. So, what are the differential diagnosis of pneumonia? The most important diagnosis is TB, as we live in that part of the world where TB is most prevalent. So, first is TB, then pneumonia can also be confused with pulmonary edema. Then we have pulmonary infarction secondary to pulmonary embolism will also present same as pneumonia. Then other less common findings, less common diagnoses are pulmonary eosinophilia, bronchoalveolar cell carcinoma, and cryptogenic organizing pneumonia, or BOOP, which is also bronchiolitis obliterans organizing pneumonia. So these are the important differential diagnosis of pneumonia, out of which pulmonary TB, pulmonary edema, and pulmonary infarction secondary to pulmonary embolism are important ones. Now we move forward into the investigations of pneumonia. So moving forward into the investigations, the first line of investigation include your good old CBC. CBC shows leukocytosis if it is a bacterial cause. So bacterial cause of pneumonia will likely show a leukocytosis with increased values. We can also do a culture and sensitivity of the blood. Then we move forward into the diagnosis. We can do renal function test. On renal function test, the urea is increased and sodium is decreased. So it can point towards our diagnosis of pneumonia. We also can order a liver function test, which can be deranged in case of basal pneumonia as it can cause hepatitis. We can also order gram stain for and culture and sensitivity of the sputum we take as a sample. Then the most important investigation in case of pneumonia is our X-ray, chest X-ray. So on chest X-ray, what are the findings? It is very important question in our exams and our vivas. So what are the findings on chest X-ray? On lobar pneumonia, we can see a ear bronchogram which we can see in the picture, the ear bronchogram. So basically what happens is there is a consolidation of the lung parenchyma. So the underlying bronchioles can be easily visible as radiolucent, but the surrounding lung parenchyma appears as radio opaque. So we can see the classical ear bronchogram on chest X-ray, which is suggestive of lobar pneumonia. On bronchopneumonia, there is patchy and segmental shadowing. Look at this area. There is a patchy and segmental shadowing of the lung fields, which will suggest to a diagnosis of bronchopneumonia. This is the table I have taken from Davidson, so we can know about the investigations which we do into the in pneumonia. So basically we have already discussed these investigations: full blood count, urea and electrolytes, liver function test, blood culture, ABG in case of acidosis or respiratory failure. I missed a important investigation, that is our procalcitonin. A high procalcitonin is suggestive of bacterial rather than viral etiology of pneumonia. We already have discussed the sputum, the swab and the urine. Now, moving further into the management of pneumonia. So we have discussed up to now, we have discussed the basic, the clinical findings, the clinical presentation, the clinical findings of pneumonia, and the diagnosis and investigations done in case of a person presenting with consolidated lung. Now, the most important part of this module is the management of pneumonia. So what are the principles of management of pneumonia? The principles of management of pneumonia is based on the decision of treatment setting. Either we treat the patient on the basis of outpatient, inpatient, or as a guideline of ICU management. So what do we do? Then the next principle in management of pneumonia is very important, that is prompt initiation of treatment, which is also referred as hit hard and hit early with antibiotics. Now, after starting initiation of antibiotics, we provide antimicrobial therapy according to the organism isolated. So these are the principles of management of pneumonia. Now, a very important topic in case of pneumonia is the CORB-65 scoring for assessing the need for hospitalization. So what is the CORB-65 scoring? Any patient presenting with pneumonia should be hospitalized or not is based on this scoring. So CORB-65 refers to C as confusion, U as urea more than 7 millimoles per liter. R, that is the respiratory rate, is more than 30 breaths per minute. Blood pressure of decreased blood pressure, that is systolic less than 90 and diastolic blood pressure less than 60, and 65 refers to the age of the patient, that is age above 65. Each of these parameters is given a 1 point. So we group the patients on the basis of this scoring, the scores they get. So group 1 patient, that is a CORP 65 score of 0 or 1, is suitable for home treatment. That is outpatient department. We provide medication and the patient is treated at home. The group 2 patients, that is a score of 2, will be hospitalized for treatment, and the group 3 patients, that is CORP 65 score of 3 and above, will be admitted in the ICU and treated accordingly. So CORP 65 scoring is very important in our hospital settings to manage the patient and to make a decision on treatment setting. Now moving forward to the management. We have divided the management of pneumonia into general management and specific management. Under general management, we first maintain the oxygenation of the patient to a saturation of 94% and above. What are the indications of oxygen therapy? Hypoxemia, hypotension, and acidosis. If any of these three are present, then we start oxygen therapy in the patient. Then we maintain the proper fluid and electrolyte of the patient by providing fluid and electrolyte therapy. Then we come to the specific management, that is antibiotic therapy. As we have learned from the principle of management that we should hit hard and hit early with antibiotics, and we won't wait for the culture reports, that and start the antibiotic therapy within 4 hours of diagnosis of community acquired pneumonia. So we have divided the management as inpatient department. Harrison has divided the management of pneumonia as outpatient management, inpatient management, and ICU management. So I have taken this resume from Harrison. The outpatient department management of patients with community acquired pneumonia, under which we have two groups of patients. One group has no comorbidities or risk factor for antibiotic resistance, while the other group has comorbidities or some risk factor of antibiotic resistance. So the first group is treated with amoxicillin 1 gram thrice a day, along with azithromycin 500 mg on day 1 and then 250 mg on day 2 to 5 for 5 days. So our treatment is amoxicillin 1 gram thrice a day for 5 days, along with azithromycin 500 mg on day 1 and 250 mg on day 2 to 5. We can also substitute azithromycin with doxycycline 100 mg BD. Now, the second group of patient with some risk factor of antibiotic resistance or some comorbidities are given amoxiclav 625 mg thrice daily plus azithromycin or doxycycline, both of which are continued up to 5 days. Now, the second class of management, that is inpatient management, which is a score of 2 according to our scoring curve 65. The inpatient management of community acquired pneumonia, we provide the patient with beta lactam antibiotics along with macrolides or beta lactam with fluoroquinolones. So we can treat either way. So inpatiently we manage the patient with ampicillin or solvactam, ampicillin plus solvactam 1.5 gram QID IV or piperacillin plus tazobactam 4.5 gram QID IV. If there is history of prior respiratory isolation or hospitalization, then we should add some therapy. We should add the therapy for methicillin resistant Staph aureus or P. aeruginosa. If there is no response of treatment, if there is no response to treatment for about 48 hours, we should suspect any complication which we will study in our which we will study in the further slides. Now, this is the exact table from Harrison, which we already discussed about the outpatient management of pneumonia. This is the inpatient management for community acquired pneumonia. Now, this is a table from Davidson, but I guess this table is of no use as Harrison has clearly mentioned and divided the treatment regimen for outpatient and inpatient management. So this table is of very little value to us. Now, the most important question you get during your vivas: what are the complications of pneumonia? We try to say one, we forget another. So I have divided, or rather the book has divided the complications as pulmonary and extrapulmonary complications of pneumonia. Under pulmonary complications, we have the most common complication, that is the parapneumonic effusion. Then we have empyema, which is pus in the pleural cavity. Then lobar collapse, lung abscess, pneumothorax, and acute respiratory distress syndrome. So, now the extrapulmonary complications of pneumonia are pericarditis, myocarditis, hepatitis, any ectopic abscess in case of Staph aureus related pneumonia, arrhythmias, septicemia, renal failure, and meningitis. So the most important ones are pericarditis, myocarditis, hepatitis in case of basal pneumonia, and septicemia, meningitis, and renal failure. So we know about the parapneumonic effusion in case of pneumonia, why it happens. Then the pus. In case of pneumonia, there is pus collection in the pleural cavity, which leading to empyema. The foci, the bacterial foci, along with the consolidated part, which disrupts the bronchial. If disrupts the bronchial wall, then causes obstruction at the bronchi, leading to lobar collapse and pneumothorax. We also know that the foci of bacteria and the consolidated tissue can rupture or can penetrate through the lung tissues and penetrate through the lung parenchyma, leading to its disruption and pneumothorax. So we move further into our discussion of prognosis of pneumonia. Many patients respond promptly to antibiotics. Fever resolves after few days, and it may take several weeks to resolve the chest X-ray completely. But cough, cough can take a bit more time to resolve. Now, what we can do to prevent pneumonia? So the prophylaxis of pneumonia. The first prophylaxis, which I have kept in number 3, is minimize risk factors for community acquired pneumonia mentioned above. Then we also have vaccination against pneumococci. PPSV 23 and pneumococcal vaccine 13 are available in USA, but PCV 10 is available in Nepal. So we can take these vaccination shots time and again to be protected from pneumonia. Also, the government is providing influenza shots during epidemics of influenza in high risk patients. Now, let us discuss some extra points in case of medicine, but it is the most important question in your pediatrics posting and pediatric exams, that is pneumonia etiology in pediatrics group according to age. So for in first 2 months, this piece of information I have taken from your OP guide. So in the first 2 months, the most important organisms or the most common organisms causing pneumonia in the first 2 months of life are the gram negative organisms, that is the Klebsiella and the E. coli. Between age 3 months to 3 years, H. influenza, Streptococcus and Staphylococcus are the most commonly isolated organisms, and after 3 years of age, pneumococci and staphylococci are the most common organisms isolated in these age groups. So with this, we conclude our discussion on the topic pneumonia. It is a very important topic, and as medical students, we all should know the in and out, the crux of the disease wholly. Thank you everyone.